All right. So, whoops, that wasn't supposed to happen. All right. So, exercise. So, I will preface what we're about to say. So, again, physical therapy world is a blend of art and science. So, our goal is to stay a lot in the science piece. Well, your whole education should be geared mostly to that. Although there are plenty of times when the art will break some of the rules we'll talk about, and hopefully I can illuminate when that is. I have my thoughts about some exercise with physical therapy. I am critical of our world of physical therapy. I think for exercise in the physical therapy world, we underdose quite a bit. And if you see a patient with 20 exercises, all with the yellow TheraBand, that's what I mean. We can do a lot less exercise with appropriate load and be really efficient and do a really good job, but we just have to convince our patients, one, don't be afraid of the blue or black TheraBand, or God forbid a weight. So I will go into some of that. I will try to make sure I tell you the lines we have to stay in, and then some other things to think of. And I think if you're a tech, you'll be able to. I saw a couple of smirks already, so I think you'll be able to understand what I mean about that. So I think exercise is the most important intervention we have in the physical therapy world. There are some therapists that don't order it at the top, but I think it's the number one most important thing we can do because we're trying to optimize movement. And I think one of the best ways we can do that is with moving, right? So in general, the goals are to improve metabolic, physiologic function or capacity of the muscle, maintain or improve range of motion, joint motion, enhance efficiency of cardiopulmonary system, and improve independent function of the body. We can affect strength, endurance, joint flexibility, one's general sense of health. I think it's for mostly we're going to talk about the kind of the mechanical benefits of exercise, but especially our trainers that are here, or even our techs that have seen this with some patients, what happens emotionally and mentally when we get somebody to exercise for 4 to 8 weeks? The confidence grows, their outlook on life is better. All of a sudden, the people cutting them off in traffic isn't that big of a deal anymore. Sleep is like, it affects so many other things. You guys that are techs, have you seen patients who've never exercised, but all of a sudden come 2 to 3 times a week, and all of a sudden they start exercising, realizing it's not the boogeyman they always thought, and like they just change. You've seen some of that, and it's really, really powerful when we get to see that. So, two broad types of exercise, active and then passive. We talked about that a lot already. And then there's subtypes we'll talk about further. So active requires the patient to assist or independently perform exercise with the use of active voluntary contraction of muscle. Passive for patients who aren't able or aren't permitted to contract muscles. Reasons could be adverse effects to the cardiopulmonary system, musculoskeletal system, neuromuscular system, or because of pain. So all of those reasons could be reasons not to. I think that the most frequently that the patient's not allowed to contract a muscle is because of post-surgical restrictions. That's the number one most common. There's some other wacky conditions out there that you would say like, oh wow, I can't believe you have this. But really that's the big one. And then because of pain, that's one of those art things as well. But so why we get paid by insurances and why we are in the medical system is because we can make really tough decisions. And it's really easy for people that aren't making our decisions to think like, oh, you want to strengthen your back? Here's the back exercise. And that's a okay thought, but that's very low level. What we're going to be making decisions on exercise for is in consideration of what is the patient goals, What is gravity doing? Do I want to use gravity or do I want to avoid gravity? How much stability or support am I going to give my patient? What's the purpose of this exercise? How much can the patient perform? What safety measures do I need to? Not only safety for like internal to the patient, is this going to be okay? Is this going to aggravate an injury? Looking at the patient's symptoms, worsening the condition. So we've got a ton of things, ton of factors to think about. So quickly, support versus stabilization. We might need to provide support to relieve stress of a joint, control the weight of the limb or body part, or compensate for weak muscles. So just a little bit of terms, just like, signs and symptoms are used kind of together and they're almost used interchangeably a lot, but they do mean different things. Support and stabilization do mean different things as well. Support promotes motion, stabilization limits movement. So when my patient, let's say they're going to, they're doing big bicep curls and they just can't do it. They need me to help them with the bar. What is that? Support or stabilization? Support. Let's say we're first trying to get them to do that exercise and they're using their trunk to do it, right? If you go to the gym, you'll see that a lot. And we say, okay, put your back against the wall, now do it. What do we just give them? Stabilization. Good. So I think a lot of times we use these terms interchangeably, but they do mean different things. And I think that's important for us to really understand. So here's the next thing. So I just talked about a lot of the factors that go into selection of appropriate exercise. Some other factors, we have to apply knowledge of torque, force couples, lever arms, arcs of motion, joint structures, muscle contractility and elasticity, stress to the skeletal, soft tissue, joint biomechanics, ligamentous and muscular attachment, sensation, neural innervation, muscle tone, and that's probably an incomplete list. So our job of selecting the right exercise isn't just my arm's weak, how do I get my arm stronger? Like there's a whole lot more that we're factoring in. And if we think back to week 1, when we're learning how to roll out of bed or teach our patients how to get out of bed, how many things were we thinking of just rolling out of bed? Way more than when I always joke, what are you going to talk about when you get home? What'd you learn today, honey? And you say, well, we learned how to get out of bed. Like whoever you're telling that to is going to think like, you spent 7 hours learning how to roll it. Yeah, and we're not done yet. We got to talk more on next week about it. So same kind of thing. We think there's so many factors to this exercise. We make it look easy. That's why people who aren't us think what we do is easy, but it's not easy. So obviously we measure everything. So when we're talking about either active range of motion or passive range of motion, the outcomes we're trying to improve is strength. We should be able to measure that in some way. The easiest way to do it is with a manual muscle test. We should be seeing improvements in manual muscle tests as we do this. If we're doing passive range of motion, we should be seeing range of motion increase with our goniometer, right? So we should be able to measure this and make sure we're progressing well. So some of the things we'll talk about later on is, the planes of motion and how do we make sure that we're acting within the plane of motion that we want? What is the task that person's trying to do? If my person, let's think recreationally, I've had patients who are elite horseshoe athletes. Like they go around, they're, I guess, professional horseshoe athletes. He blew out his pec and his big goal is to get back to horseshoe. Which plane of motion is that activity primarily in? Sagittal plane. I've had elite baseball players, if we're talking about hitting a baseball and not pitching, although pitching we could talk about a lot too. What plane of motion is hitting a baseball primarily in? Mostly transverse, right? So yeah, knowing which plane of motion we want to essentially is really important as well. We can get really deep into that at some point if we want, but I'm going to try to keep things simple. So the types of range of motion, we're going to mostly talk about passive range of motion, active assist, active range of motion, and resistive. Now, without even learning about this, I think we've already learned about this enough without talking about it yet today. Which one of these would you select if you wanted to increase range of motion? Passive range of motion. Any other answers? Active assist could. Yep. Which one of these would you select if you wanted to increase strength? Resistive, active, and active assist. Yep. So we've got potentially 2 selections if we want to increase range of motion, potentially 3 if we wanted to increase strength. And part of our skill is to know which one to do when. So we'll talk about passive range of motion first. Movement of the joint without active contraction of the patient. External force is applied. Easiest to think of as manual force from us. That's the easiest and most common way that we're going to do it. Although we could use mechanical weights, pulleys, effects of gravity. Who's ever seen prone knee hangs for knee extension? Right, so that's where the patient lays down on the table. We have them hang their leg off, right? They've got some sort of knee extension limitation, and we just let gravity do it. Make this harder. What would we do? Put an ankle weight on it. Good. So that's what we mean. That's still a passive range of motion exercise. But instead of me pushing on the patient, man, if I can use a sandbag to do my job for me, I will gladly let it. So we'll talk not only I think today, but also next semester when we talk about thermal modalities. When should we put ice and when should we put heat? And there's some really interesting thoughts that we could do with that as well. So yes, we could use passive range of motion in addition to modalities too. That's a great thought to it too. So there's a lot of ways we could do that. But I think for the most part, manually is one of the most common ways to do it. Art piece of it. There's something powerful when we place our hands on somebody else for the effect of healing. There's the physical like power of touch that can be really important as well. So I will always let the ankle weight do my job if it can, but I will always put my hands on a patient too. I think there's some power that goes, that's part of the art thing though. So technically passive range of motion is to maintain joint motion while stretching is used to increase range of motion. Although I see these used interchangeably. I think if we are in the clinic tomorrow, if we were to say passive range of motion, most clinicians would think of stretching. They would say, oh yeah, I'm going to improve range of motion. Technically speaking, passive range of motion is only used to maintain motion while stretching is used to increase it. That's a very technical thing that I think clinically they're used interchangeably. So benefits of passive range of motion, one, preserving range of motion. So I have a patient right now. He had a traumatic brain injury. It's close to 20 years ago now. He's comatose, and every other week I go in and do passive range of motion to him. And the reasons for that is because I want to minimize contracture formation. What's contracture again? Yeah, joints getting stuck, right? Lack of motion. Anybody know the physiology why that happens? Exactly, it has to do with the sarcomeres. So what are sarcomeres? Oh, yeah. Back to anatomy and physiology 1. We got to dig back to that. So it's the muscle fibers, it's the motor, it's the unit of the muscle fiber. So what they do is they require energy to have lots of sarcomeres, right? So that's why our power lifters or our bodybuilders can eat. How many calories a day do bodybuilders eat? Yeah, that's true. So, and why can bodybuilders take in that amount of calories and not just get completely doughy? Is because the muscles, the sarcomeres, require a ton of energy, right? So, does the body like to expend a bunch of energy? No, the body wants to be water. It wants to be level. It wants to be calm. It wants as little things happening as possible. Because when something needs to happen, we need all those energy stores, and we don't, there's a lot of other reasons for that. So, if my person who is comatose, his body doesn't need all those sarcomeres, the body will get rid of those sarcomeres because we don't have all these energy demands. So if we allow the person to stay in one position, the muscle length will shorten and the number of sarcomeres is way less than if we were to have active motion. So that's why contractures happen. So my job is to fight that, right? To keep him as improved range of motion as possible, maintain as full range of motion as possible. Now, this person, TBI almost 20 years ago, what's the prognosis for him? Is he going to get better? No. So why am I doing it? Why not just let him have contractures? Yep, some quality. Tell me more about that quality of life that he does have. So what else about that quality of life are we concerned with? Yep. Yep. So you're absolutely right. There are some feelings he still has, and potentially some emotions he still has. And when I stretch his hamstrings, he'll let me know what he's feeling. He does. So yes, he does have feelings and emotions and pain, and yes, absolutely. What else? Well, I'm not sure if they hurt. Getting rid of them hurts, but it can lead to pressure injuries, right? If my person has 30-degree knee flexion contractures, he's in the wheelchair most of the time. What's he look like when he's laying supine in bed? He's got 30-degree knee flexion. What does that increase the amount of pressure on when he's laying supine in bed? Ischial tubes and sacrum and heels, right? So yeah, we're never offloading those areas if we add a contracture, right? So good. So risk of pressure injuries is huge. Now, if he also gets a pressure injury, we're unsure of the amount of sensation that he has. For most people, when they get pressure injuries, they lack sensation. That's why they developed it, but we're unsure of how much sensation he has. That might be really painful for him. How old is he? He is in his mid-40s. Yeah. So yeah, I think a lot of reasons that you guys talked about. Prevention of contractures really important. The quarter threes learned about prosthetics a little bit ago. We learned about prosthetics briefly with positioning. What's the contracture? What's the injury that we're really concerned with contractures about when we talked about positioning? Transtibial and transfemoral amputations. Transtibial, I'm a little bit more worried about, and that was that knee flexion contracture, because how do we get rid of that knee flexion contracture? We have to do what? Stretch the hamstrings. But if we chop off most of the tibia, we don't have the lever arm to stretch the ham. It becomes really, really difficult. And what's the reason we want to prevent those contractures? Not only does it make our job really hard down the road, we don't want to do that. What else about the patient is going to be really troublesome if we allow them to have a contracture in a transtibial? The fitted prosthetic, and how does a prosthetic work? Now all of a sudden the prosthetic won't help them. So yeah, we have lots of reasons why we want to prevent contractures. Minimize adhesion formation. The mechanical elasticity of muscle is really important. And again, I use the contractures for my patient who has limited prognosis. There are plenty of patients that we will need to preserve this for the time because they do have positive prognosis. They will get better. Guillain-Barré is one of those that, the patient gets really bad really quick, but then they're going to recover. There's lots of others. And there's also, if we think of just the post-surgical, don't move your arm for 6 to 8 weeks. We want to preserve as much motion as we can. We can move their limb. The patient can't move it themselves because of their restrictions, but we want to preserve the mechanical elasticity of the muscle. We want to promote local circulation, promote awareness of the joint, enhance cartilage nutrition and movement of synovial fluid, and reduction of pain. So I think all of those reasons are really beneficial for passive range of motion. Indication: patient is unable to perform active range of motion, paralysis, comatose, pain with active contraction, post-surgical active contraction restrictions. Again, that's probably the most common one we'll see. Contraindications: when passive range of motion increases the patient's symptoms, or restrictions from surgeons and MDs. I think the easiest one we've already talked about is hip replacement precautions, right? Flex to 90, don't flex past 90, right? So we would still be able to flex to 90, but we're not going to go past that. So principles: so requires firm but gentle support and stabilization. Firm but gentle is a tough, those feel like competing statements. I think, does that statement though make sense to us in this room? And I've talked about this a little bit, when our patients are really nervous about having their joint moved, when we're doing something to it or we're measuring it, just a firmer squeeze in your hand, right? You have their wrist, you have their elbow in your hands, you're about to do shoulder flexion, and they're nervous, and all you got to do is just squeeze your hand around their wrist a little bit more. It just feels like you're holding them safer. So proper hand placement and control. Avoid stress to structures or the segment being moved. Best hand placement, area of grasp, that will depend slightly on our size, our patient's size, how much motion we're able to get. There's a lot of variability to it. And I think the people who work as techs, when you watch your patients, how your therapist position their hands are going to vary quite a bit. And that therapist will not even be thinking about that little adjustments that they made. It's just going to be automatic. So we'll think about that. Smooth, controlled, complete motion with minimal adjustments. We don't want to be switching our hand positions all a bunch. The more we have to switch our hand positions, the less control we have over our patient, and the more they're going to want to actively contract. And if they shouldn't be, that's a problem for us. All planes of motion in the entire range should be exercised. Assessing end feel is important as well. Initially, one joint at a time, but can advance to multi-joint passive range of motion with knowledge of the patient's abilities, therapist practice, and maintaining restrictions as possible as well. The other thing we have to consider is, if we want to work on a joint, the multi-joint muscles that cross that joint should be put on slack. So if we want to do hip flexion, what position should the knee be in? Should be in flexion as well, right? Because what did we just place on slack? Hamstrings, because if we had the leg straight, we would do hamstring passive range of motion and not hip joint range of motion. And again, we might need to do both. We might need to do just one. We have to consider, what are we doing in relation to everything else we already mentioned. So there's not just one answer. So multi-joint muscles: biceps, triceps, extrinsic finger flexors and extensors. Quick note on that: for patients with intact C6 spinal cord injury, stretching the long finger flexors is contraindicated. Why? Because we want a little bit of TNODs, and we want a little bit of restrictions so they can still grasp objects, or at least place objects in their hands. And so stretching of that is contraindicated. And other patients might benefit with some sort of finger flexor tightness for that reason itself. So I've got plenty of patients that don't have active grip, but they can still hold the remote control of the TV or other objects in their hand because they have just enough of that tightness in their hand. Hamstrings, rectus femoris, gastrocs. So for these, now we want to make sure that we are stretching across both joints as well. So positioning your patients to observe the patient's face if able, that's something we've talked about a lot. I like seeing my patient's face. My patient's face will alert me to discomfort way faster than their words ever will. So if I can see their face, it's great. It also helps with the patient. What are we doing, especially those nervous patients? Maintaining proper body mechanics. We don't have research on specified frequency repetitions of passive range of motion. We have a lot better strengthening exercise research that's done. How much passive range of motion is needed to maintain motion and all of those other benefits, we don't have exact prescriptions for. What would we do if we don't have exact prescriptions, if we don't have exact guidance? Accessivation. So I've been seeing for years now. I see him every other week. We're doing great. If we weren't doing great, how would I know or to assess? And what would I specifically assess? Measurements, range of motion. How are we doing? Does this knee go straight? Grab the goniometer and bend the knee too, if make sure the knee is at good range of motion. So take measurements and track over time. If this guy is losing range of motion, I need to do what? Do more. And that more might be, instead of 45 minutes every other week, maybe I just need to do an hour. Maybe I need to do 3 times a week instead of 2. I mean, sorry, 3 times a month instead of 2 times a month, right? So we can talk about frequent time. We could also talk about frequency. I don't think intensity for me is a problem. Intensity is how much force am I putting into them, right? So, but yeah, make adjustments. And then how would I know if that adjustment is working or not? Remeasure. Yeah. We're not always going to have exact guidance in the physical therapy world. We're not going to always have well, what does the textbook say about what should I do? We do something and then remeasure. And sometimes that remeasurement could be immediately after, or sometimes it's going to be, hey, we've tried this out for a week and a half now. Let's remeasure and make sure we're making some progress or not. So yes, you guys have the tools to determine if what you're doing is right or not, because you're measuring things. We're going to look at, there's a bunch of pictures in the textbook about how to do this. Traditional anatomical plans. We'll also look at diagonals. Let's wait a minute on diagonals. So what I want at first, let's try these multi-joint muscles first. So let's do passive range of motion to these multi-joint muscles. Now, if we're doing passive range of motion, what should the patient be feeling? If they're feeling a stretch, what are we doing? We're stretching. Okay, so what I want for now is passive range of motion, which means we as a clinician bring that muscle to its end range. Once we feel tissue tension, that is the end of their range, and I'm going to stop there. Now, if you stopped at end range and held it, versus if you did multiple smooth repetitions, again, research doesn't guide us on exactly what to do. Try them both and see what you feel like. If we wanted to stretch, what would the conversation be like? And then tell me the parameters for it. First, the conversation. What's the conversation? Tell me when you feel it. Tell me where you feel it. can I go any further? And then you keep calibrating, kind of go further until they say, no, that's it. That's their maximal stretch. How long do we hold that for? Between 30 and 60 seconds, depending on age of the person. Make your best call. And then what's the total time that we would do that for? 3 minutes. 3 minutes. So yeah, great. So if you hold it for 1 minute, you do it 3 times. If you hold it for 30 seconds, you do it 6. But right now, I really want to focus on passive range of motion, and that's you as the clinician feeling that tissue tension. Once you feel that tissue tension, you're entering into stretch, and we don't want to do that. We want to just maintain for now, okay? All right, do we need demonstrations on these? Can't hurt. All right, let me use, mind if I use this table here? Who's got biceps, triceps, hamstrings for me? You volunteering? You're checking it. Like, yeah, I think I have them today. Yeah, good. Why don't we come on up here? Your hip okay for hamstrings and quads too? Okay. Yeah. All right. So, and then coming up to this corner as much as you can. All right, so tricep, let's go in order. Biceps. So biceps, you guys remember what are the motions that the biceps performs? It performs supination, shoulder flexion, Jesus, and elbow flexion. What would Freud say about why he went from supination to shoulder? There's something there. All right, so in order to provide passive range of motion and then eventually stretch, I would need to do the opposite of those. So pronation, shoulder extension, and an elbow extension. That's the order I like to do it in. Again, that's just because I like to put my goniometer right on the elbow so I can measure that. If you did elbow, whatever order you do that in is fine. Just make sure you're putting stress across all 3 of those motions, or else you're not providing. If I held them in supination here, I'm not at end range for the tissue, right? So I want to perform all of those. So I like to do it this way. If you wanted to mix up your order, you could. So there's that. And as soon as I feel that tissue tension, I back off. Whether I hold it here for a little bit or if I just glide in and glide out, either way, again, no specific research. You figure out what you like to do. All right, so there's my biceps. Triceps, what motions does the triceps do? Extension of the elbow, extension of the shoulder. So I have to do the opposite. I have to go into full shoulder flexion and then add my elbow on top of that. This table is a little bit in my way. I'd have to readjust position for that, but that's where I would be for that. All right, so there's that. Long finger flexors and extensors. I prefer seated with this one. Come on, Elvis. Actually, I'll just show you here. So making sure that we're in wrist extension and finger extension. And again, I like providing force throughout the entire, making sure I've got great contact at the tips. I don't want to put the IPs in hyperextension. So I make sure I have good contact, whether you go finger to finger like that or palm to fingers, it doesn't matter, whatever you like. Okay. And then for the finger extensors, I need finger flexion with wrist flexion. We can just, again, glide in and out like that if you need. Hamstrings. So we have 2 different ways that we measured it, right? What were those 2 ways? Straight leg raise or 90-90. Providing passive range of motion as long as you cross both joints to its end range. I don't care which way you do it with. I like the straight leg raise because I feel like I can minimize the substitution at the knee the easiest. So I want to make sure I maintain that knee extension. And again, as soon as I feel tissue tension here, I'm going to start sliding back. That's the end of my passive range. If I hold it here, first I need to have that conversation. Second, I'm in doing what? Stretching. Yeah. There might be a time we want to do that, but right now we're focusing on just passive range of motion. Okay. You could do it this way here. and just work on that would also be hamstring passive range. Rectus, let's do gastrocs first since we're here. Can I take this shoe off? So gastrocs are tough. We don't have a long lever arm, right? The even really, unless you're Sideshow Bob. Anybody know a Sideshow Bob? So Sideshow Bob would be able to do that. But we don't have a long lever arm here. So I've got to add a little bit more force here. So what I'm going to do is I'm going to grab the calcaneus and I'm going to pull. It's a lot like remember when we were doing scat mobilizations where we had to have two hands to provide enough torque. So what I'm going to do is I'm going to grab the calcaneus and I'm going to pull inferior. I'm going to pull the calcaneus that way. And then what I'm going to do with my forearm is I'm going to lean in, and now my forearm's going to add dorsiflexion of the rest of the foot. So I'm trying to provide that force couple. My hand pulling the calcaneus that way, my forearm pushing into dorsiflexion there. Okay, so there's where I feel tissue tension, glide in and out, hold for a few seconds, and then glide back, and then go back. Again, you figure it out, and then measure and make sure you're doing what you need to. And this is exactly how I would stretch somebody's gastrocs as well. I put my hand right here on their knee. Why? To prevent knee flexion from happening. So again, calcaneus comes this way, forearm to create that torque for dorsiflexion, hand on the knee, and I just lean in to provide. So you feeling a stretch there? So again, I'm using just my body weight with this, which is really nice. Sometimes if I need to provide a lot of force, I go two-handed, one hand on the calcaneus, and then I bury my elbow to my body, and then I lean in with my body weight that way. You feel a lot more force there, right? So that's the other technique I do have. If you wanted to provide stretching, you can play with that a little bit because I think that's a little tricky. And then last one, rectus femoris. Flipping on over. We have a bunch of ways we could do this. If I wanted to keep them in supine, what could I do? Bring them off the edge of the table and try to drop them that way. I think the easiest way with a small bolster, put a small bolster underneath his knee. Why? What is that doing? Putting the hip in what position? Hip extension. So if I wanted to, I could do it there. Keep his ASIS down because I don't want him to substitute, and then I add my knee flexion on top of that. I like this way a lot. Disadvantage of this, I can't see his face, so that's sometimes troublesome. But this way is a pretty good way to do that. In addition to the either off the table this way or that Thomas position. Those are the other ways that we already went over. So what we want to do, try all of these muscles and really try to make sure your hands are feeling when that tissue tension is happening and trying to stay within passive range of motion, not stretching. Okay? All right, let's give it a whirl. So we're going to do passive range of motion of all of these things. We've already done some of these, so I think this is going to go quick. But stop me if I show something or say something that we need to expand upon, okay? Can I have someone on this table who wants to be my partner on this? Put this over here for now. All right, go ahead and lay down on your back. Let's have your head down this way for me. All right, so first up, we'll start with the shoulder and then work our way down. I think the key for us here is figuring out our hand placement, because what I don't want to do is I don't want to do shoulder flexion, get halfway up here, and then have to switch my hands. So having an idea of how much motion my patient has initially is going to determine exactly my hand placement. So if he's only got up to here, my hand placement here is probably fine. If he's got more than that, I'm going to have I'm going to consider my top hand, because it's not always going to be my right hand if I'm on the other side. So I'm going to have my top hand at the wrist, my bottom hand at the elbow. That way I can provide my shoulder passive range of motion. Again, I'd still like to stay within passive range of motion for now. So passive range of motion, as soon as I feel that tissue tension, I'm going to then start backing off. Okay. And it should feel different. That tissue tension, you should be able to feel the difference between glenohumeral joint versus patient apprehension of contraction of muscles, that fear of like them tightening up. So see if your patient's not fully relaxing, you should be able to start determining that with your hands. So here's, easy shoulder flexion. Extension, if I do all of these in supine. Few reasons for that. One, I can see my patient's face. Two, I don't like having my patient flop around to all different positions if I don't need to. When I'm doing range of motion testing, I want to be as perfect as possible, because that's a test, that's a number I'm getting from it. Any deviation from a perfect procedure is going to give me potential for measurement errors, and measurement errors clouds what we do clinically, and it clouds, is the patient truly making progress? Am I just making a mistake that's making the patient look better, right? So measurements, I want to be perfect. Treatment of passive range of motion, I'm okay being a little off, as long as I'm still getting anatomically what I want. I can, so for shoulder extension, slide to me, I'm okay with having to abduct his shoulder a little bit to get into shoulder extension. I don't think that's going to be a big problem as far as maintaining motion down the road. Although I'm always going to measure and then reanalyze, what am I doing? Is there anything I could be doing better? Right. So, does that make sense to everybody? Why measurements, I try to be precise. Treatments, I get to be there's a little bit more gray area. Does that make sense? So shoulder extension is a piece of cake. I prefer having a stool with it. And yeah, just nice, easy shoulder extension. There's a piece of cake there. We can go to this edge, middle of the table. Shoulder abduction. I'm going to really use this corner of the table. I think we did that before. If they have adequate motion, I'm going to be on this side of his arm. If he's limited, I'm going to be on this side of the arm, right? So this side, I get to say, oh, that's all we've got. If he's got good motion, I get to be here, and I get to come around the corner of the table to add that. So really making sure you're using that corner of the table that you can come around, rather than, getting here and then not knowing where to go, right? Because the table's in the way. So use this corner. All right, so there's my shoulder abduction. I put question mark adduction on my list because I've never had to provide adduction to somebody. It's there. It's never a problem. So we'll write it down and we'll put a question mark to it. Okay. Shoulder IR or an ER, I like to have here. Towels or not, up to you. You can see me using my little hip block, my hip shelf. Here's my shoulder internal. Here's my shoulder external. The hand on the shoulder, I'm not stabilizing I'm not putting force into the head of the humerus to keep it there like I would be if I wanted to stretch. I'm just doing it for patient comfort. You're okay, right? That's all that is. So there's my shoulder IR and ER. And then my shoulder horizontal horizontal ABD, I'd have him slide to me just a little bit more. And I just do off the table that way. Okay. So there we are. All right. Is that everything for shoulder? Yep. All right. Slide to the center. Elbow flexion extension, piece of cake. I mean, do we need to go over that? Forearm pronation, supination, wrist flexion and extension. So again, make sure that if you are working on the joint, the muscles that cross the joint are on slack. So just make sure that you're doing that. Radial and ulnar deviations, whether you do it there or here, either way is fine. Hip. So hip flexion, I want to make sure the knee is in what position now? Flex now. So I like to have my hand right below the knee, and then we get to push into hip flexion. This is one that the size of the limb of the patient is going to really determine your mechanics quite a bit. I'm always a big fan of having the patient slide to me. You know, just that 2 or 3 inches eliminates so much of my trunk flexion over the edge of the table. So making sure that they're as close to you as possible for hip, I do think is really important. So here to here, I was talking with Tanner. He has one therapist that puts the foot on their shoulder as they do that. I don't love that. You guys see that when in the clinic? I don't love that because I don't like feet near my face. Although your personal body size and the patient's size of their limb mean that's going to determine how I do that. I can always, if I do put that, I always put the towel on me and as a barrier between their foot and my shoulder. So anyway, you feel free to play around with that as much as you can. So there's my flexion. Extension. Again, I like patients in supine and I like bringing their hip into extension this way. Although what other positions could we do? I could do prone. I hate prone. Why do I hate prone? Heavy leg against gravity. Oh, but if I have to, I will. My preferred way is side lying. And when we went through this exercise too, we were specifically stretching of the hip into hip extension. Same thing with passive range of motion, although we're not providing the extra force into stretching. What were your personal preferences? What positions do you guys like to stretch to move into hip extension? Supine off this way, off the edge of the table, not necessarily the front of the table. Yep. Any others? For me, I like side lying the best. I think I get the best torque and I get to lean with my body weight. Although this supine is pretty good for some people. Some people just can't relax on the edge of the table, and they're just so nervous about falling off the edge of the table, even though I've never had anybody close to that, but they're nervous about it. I can't get them to relax to do it. So all right, so there's my hip extension, couple ways for that. We already did flexion. Ab and adduction. Again, I'm here to here. Slide to the edge of the table. You're making me nervous. Slide to the center of the table. Sorry. So you know, here to here, and again, feeling until we hit that tissue tension, then backing off. You can see I'm rocking with my body on all. Whenever I'm always trying to use my body and not just my arms to move something around, right? So I'm really trying to make sure that we're doing that. Adduction, again, I've never had to do adduction before, but if we needed to, we could. IR and ER, we've got a couple ways to do it. One, just in this long leg position, just rolling. I'm making sure I'm grabbing the femur and the tibia to guide and to roll both. I don't want to be just one or the other, so I'm rolling both into IR, or this is ER. I also like doing it in this 90-90 position too. That's the other way that I like doing it. Play around with both of those. Knee flexion extension, gosh, you know, piece of cake. I prefer here. Again, this is another one where you could use your body weight to push into knee flexion. I don't love doing that. I like this here. But again, your patient's limbs will determine a lot of how your mechanics are. And then extension here. Extension here, if we could always have a knee block, you know, either using our knee as a bolster or a real bolster to move into knee extension as well. Ankle, can I take this shoe off? And then ankle, plantar flexion and dorsiflexion. If I'm going to do this, I need their knee into slight flexion, right? Why? I want to eliminate the gastrocs from being the thing I'm doing passive range of motion too. So here's my ankle dorsiflexion, ankle plantar flexion, inversion or eversion. I could do there too. All right, there you go. What else? All right, cervical we've done. I've never, I shouldn't say never. The amount of times I've passively moved somebody with cervical flexion and extension is really minimal. I've stretched upper traps a ton. I've stretched levator scaps a ton. I can't think of a time where I really needed to move into flexion extension, although someone here will say, "Hey, Josh, I can't believe I had to do this." So, flexion is pretty easy, right? Keep on relaxing to my hands. There we go. Good. So flexion is pretty easy. Extension's a little tougher because I have to get my patient coming off the table to me. So now I'm here and I'm controlling the head going back. Having my patient relax to let me do this is really tough. I don't have great success with this. I might have better success, slide down. I might have better success if they're sidelying maybe and moving in that direction. That way they can rest against the pillow. I haven't had to really do that. Yeah. So if he's resting in the pillow, now I can move him into flexion extension with keeping him. Like it's a scary feeling dropping a head off the edge of the bed. Anyway, thank you. Go back supine. Definitely side bend and rotation though. So side bend, rotation. And for these, for passive range of motion, I'm using both hands underneath their head. And I'm controlling with both hands. And same thing, rotation, going that way. If I wanted to do stretching, I would take one hand and I would do my one-handed cradle technique, my hands like that underneath of his head. And then my other hand would stabilize his shoulder as I wanted to put that tissue on stretch. So that's cervical. Trunk. I'll show it to you. I have some thoughts on passive with a trunk. One, lots of force I need to produce. Two, I think I can passive range of motion of trunk. Gosh, who needs that? So I'll show you, and then you guys figure out if you ever need to. And actually, you guys that are techs, if you see, if you tell me if any of this looks familiar. So trunk flexion, I would need to bend both hips and force the patient that way, right? So again, I've never really had to do this, but okay, it's in the book, so we'll show it to you real quick. Rotation. I then am going to put him in almost this hook lying position, stabilize here, and then add rotation this way. Or this way. Oh, yeah? Yeah. Do you know why? Bigger movements you want to do? Yep. 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 Yeah. 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 All right. I could see that. Yeah. So we'll show it to you. I think other than that though, do you see a lot of other, and about you guys that are other techs? Yeah. Yep. Yep. Oh yeah. Huh. Pelvic floor, you see it with a lot of that. That makes sense to me. All right. So of the examples that we've had, Parkinson's specialty, either specialty practice or unique patient, returning to work type stuff, specialty practice, pelvic floor, specialty practice. What did you say? You've seen rotation, not flexion. So, and how often do you think you see?
Mostly it's like never happened, but
yeah. All right. So not, again, not as frequent as others. So I think it's a nice thing to have. We've had a couple of examples. I think it's a nice thing to have in your pocket. I think the number of times you'll need to is less, although if you're the back specialist, then you might be doing it a lot more than others. So let's play around. We've got a lot of these to do it, although we've been doing this throughout the semester. We've had a couple days where we've just focused on this, so I don't think it's going to take all that long. So when you're trying to figure out your hand placement, come and grab me, and then we'll keep working on mechanics and how we would do that, okay? All right, so we got a big, long list, so spend a lot of time doing it. Thank you. Any big problems with that? Easy enough because we've done it enough. All right, can we do something tough? And then we'll take a little break. All right. In order to live as humans, as functional beings, mammals, what's our primary need? Eat and drink. Eat and drink, right? All right. The second thing we need to be able to do is fight. We got to fight off invaders. You got to fight off the invading tribe from the next town over, right? So first thing is feeding. So I want everybody to get their, let's go right hand, everybody with their right hand to their mouth like this. Good. And then we don't like what we ate and we throw it behind us. All right. So that's D1 flexion and D1 extension. All right. Next thing we got to do is fight. So we don't like to fight with our hands. We like to use swords. So we're going to grab our sword from our pocket, right? Our sheath. I'm going to take it. We're going to show it to our enemies. Say, I got a big sword right here. Don't come near me, right? So we put it away and we take it out. All right. So this is D2 flexion. This is D2 extension. All right. So primary is what? Eat. Secondary is what? Fight. Okay. All right. So what we're going to do next is we're going to touch on PNF techniques, proprioceptive neuromuscular facilitation techniques. There's a whole lot of PNF techniques that we could use. When do you guys start registering for classes?
Yesterday.
Oh, really? What am I teaching? Do you know?
On Tuesday and Thursday, 8:30 to noon, and then on Tuesdays, 12:30 to 3.
All right, perfect. Sounds good. Thanks for telling me. So do you guys see there's a exercise class we could take? All right, I highly suggest that class. It's 5 weeks long. That's it. And I will tell you, it is designed to get you ready for your clinicals. So we're going to touch on neuro stuff that we don't typically get to touch on. We're going to dive deeper into exercise. If you do not have tech experience as a tech aide, you should. I would consider it mandatory. It's not mandatory, but I would consider it mandatory. And it's designed to have success on your first clinical. So the reason I bring that class up is because we're going to dive into PNF techniques in that class a little bit more. You're really going to get it in PTA 4. This is a neuro PT type of a thought process, but we're going to touch on it now. So we are going to use these techniques. These techniques could be active or passive. We can develop muscular endurance, strength, mobility, coordination, neuromuscular control. We're going to focus on these diagonal patterns. Now, as the neuro PTs of the world will be able to explain why these are really great for us. There's something about crossing midline and how crossing midline communicates to the brain, midline of our body, communicates to the brain. It enhances spatial awareness, limb awareness. Doing multi-joints at the same time can also create a lot of awareness of the limb. Again, you'll learn more in neuro. I just want to keep it like that. But We're gonna focus on diagonal patterns. So D diagonal is gonna be 1 or 2. And what we already did is upper extremity. We did D1. What was D1 again? Beating. D2 is sword. Okay. So we're gonna focus on just for the upper extremity. So when we talk about D1 flexion, it's named for the proximal joint. The proximal joint is going to be the shoulder for the upper extremity. So we move into shoulder flexion here, or move into shoulder extension here. Okay. So let's dive into it just a little bit more. So we have all of these we will be covering. We've already done 4 of them. So don't get too freaked out. So here's a decent picture on what D1, the upper extremity diagonal patterns are. D1 flexion, we can think of it as fader, flexion, adduction, and external rotation. Flexion of the elbow, oh, that's for the shoulder. Flexion of the elbow, supination, flexion and radial deviation for the wrist, and then flexion. So the examples that we talked about is eating and drinking, right? Bringing something to your mouth. D1 extension is extension, abduction, and IR. Extension of the elbow, pronation of the forearm, extension and ulnar deviation with extension of the fingers. So, this says driver's side seatbelt, putting on that driver's side seatbelt, reaching it over there. So, everybody, let's start in D1 extension now, right? And try to get the wrist right. I think we do an okay job with everything else, except let's make sure we emphasize the ulnar deviation and extension here. And then let's move into D1 flexion. We're bringing that all the way up to our mouth, focusing on the wrist flexion and radial deviation. All right, let's move into D1 extension and then D1 flexion. Let's just give like 3 or 4 reps. Really focus on the wrists. I think everything else kind of makes sense. And then, all right, can I have somebody supine here? So, sure, let's do it. Whoever. So, where we're really going to, where this can be tricky is our hand placement, because I want to be doing all of those motions to every joint at the same time. So as you first start doing it, just break it up. Do wrist first, then elbow, then shoulder. Do shoulder, then elbow, then wrist, right? Break it up a little bit. And then as you get a lot of reps with it, you'll just be really smooth with it, where you won't have to really think about it. So I'm going to start with my patient passively, so relax. I'm going to start them in D1 extension. So that's, let's see, extension, abduction, and IR. Extension with the elbow. And then we have extension, ulnar deviation with the wrist, and extension of those fingers. So I'm going to be here. So my hand placement is going to be around his elbow, and then my other hand is going to be kind of grasping the fingers, wrist, somewhere along this way. You'll have to figure out where you like that. All right, then I'm going to move him into D1 flexion. So I'm going to start with my wrist if I want to go slow. So I'm going to go into flexion and radial deviation. I'm going to go into supination, elbow flexion, and then I'm going to go into my shoulder position there. And then I'm going to move back into D1 extension. So when you get really smooth at it, you'll be able to do all of these motions in a nice, smooth way. But initially, you're going to have to really just like play with it all. Okay. I don't have a magical way to remember this stuff. So as you guys are studying, if you do have the C+T me of diagonal patterns, please share them. But for now, I think we just need a bunch of reps. And so there's my D1, both flexion and extension. My D2 now, I need to go from, right, my sword position. So I'm in flexion, abduction, and external rotation. I think the elbow is wrong. I think the elbow is supposed to be extension there. I think that's a typo. Supination, wrist extension, and radial deviation. And now I'm going to be moving into my position there. So there's my D2 position. Okay. So again, both of these are just going to take a long time. I don't have any magic to remember it other than a bunch of reps. So initial reps, just focus on, okay, wrist, what do I do with the wrist? Forearm, elbow, shoulder, do a bunch of those, and then start trying to piece it in together so it's a little smooth, okay? All right, let's play. All right, I think the lower extremity diagonal patterns I have a little bit tougher time with. The upper extremity just comes a little bit more naturally to me. So D1 flexion, think if we think of it as putting on shoes and socks, or that the sartorius motion, I think is the way that I always think of it. Extension, I think of D1 extension, I think of that, we haven't gone over it quite yet, but toe touch weight bearing, where we're not allowed to put weight in our leg, but we're allowed to put our toe down just for balance. So that's kind of what I think of that. So here's D1 extension all the way up to that sartorius for D1 flexion. So the hip D1 flexion, adduction, and external rotation. Knee flexion, ankle dorsiflexion, and inversion, and then toes and extension. So let's just either while you're sitting there or if you need to stand, go right ahead. So let's move into D1 flexion. And again, just like with the upper extremity, I think it's the foot positions that can be the ones to forget about. So make sure we're focusing on the foot. Yeah, flexion. Yeah, if you can. Yeah. And then D1 extension is extension, abduction, and IR. Extension of the plantar flexion and eversion of the foot with flexion of the toes. So let's move on back, and we can go back and forth. Now let's just get some reps. D1 flexion to D1 extension. D2, this one's the trickiest one, fire hydrant basically. So flexion, abduction, and IR. Flexion of the knee, dorsiflexion, and eversion with extension of the toes. And then D2 extension is extension, adduction, and ER. Extension of the knee, plantar flexion, and inversion of the foot with flexion of the toes. So here to here. All right, who's got a leg for me up on this table? Perfect. Supine all the way back. Take this shoe off again. All right, so D1 flexion extension again. I've got to I put my foot kind of around the midfoot so I can control that foot mechanics as well. So flexion, external rotation, and adduction, flexion of the knee, dorsiflexion, and inversion of the foot. Then I move into my D1 extension. So D1 flexion of the lower extremity, D1 extension. Okay, a little tricky. And then my D2, I'm here with my foot dorsiflexion and eversion, and then I move into D1 extension, which is here. So here to here. So a little tricky, especially if you've got really big limbs. Exactly how do you position your hand around the knee to make sure you get that hip position? We had a couple good questions about D1 patterns before. What were they? And I said, I'll ask you when we're back. So long ago. No. Well, I think it was like, why do we do this? Is that what your questions were? So, the reasons to do it have to do with more neurological reasons, getting the brain to process a lot of information at once. And when we work on multiple joints at once, the brain has to process all that information. There's something, and I can't explain the physiology behind it, but there's something about when we cross midline that really makes the brain work as well. I had one patient who, and I'm not a neuro PT, I don't see a lot of neuro conditions, some, but not a ton. I had one patient that he had Lyme disease, but it looked like he was having a stroke like that morning that I saw him. Like I wanted to call 911. That's how bad this guy looked. And I was trying my traditional methods and he was not getting better for about 2 weeks. And I said, okay, new game plan. And I did some PNF techniques with it. I did these exact things. And within 2 weeks, he made so much progress, we could go back to what my original plan was. He wasn't making progress until we started doing these diagonal patterns. And I can't explain why, because I'm not a neuro expert. You know, Pat McCormick could explain why. He's a neuro expert. By the way, did you guys meet Ed McCormick at the... So good old Abby here goes up to Ed McCormick. Ed McCormick is a guy I met once. I've met Ed McCormick once. I've had 2 conversations with him in email. I don't know him very well at all. Effing Eddie goes up to him and says, "Oh, Ed McCormick, Josh tells stories about you all the time in class." To a guy that I've met once. And Ed's, I'm sure, sitting back going, why the hell is Josh telling stories about me all the time in class? So then I had to go up to Ed and say, hey, Ed, I'm really sorry, but I don't tell stories about you all the time. I tell stories about Pat McCormick. So thank you for that. I appreciate you. Appreciate you doing that for me. Yeah, now, yeah. Now I told one story about Ed McCormick. Yeah. Yeah, he won't be taking us as students anymore. That's oh well. Anyway, so it has to do with crossing midline, and the multiple joints at once really does stuff to how the brain has to process that information and why it's so beneficial for some people. I've seen it once. I've had to use it once, and it was amazing how much better this person got once we added these things and took away what was the traditional things that I was trying for. So,
with that patient, with himself, or were you doing it?
Both. Yeah, initially, I would be doing it passively for him, and then we'd started doing strengthening exercises in these diagonal patterns. Yeah. Yep. All right, so let's practice our lower extremity diagonal patterns, okay? All right, so next up, we're going to start talking about resistance, exercise for strengthening, I should say. Now, what I'm going to do is I'm going to lecture everything. A lot of it we've already talked about, so I'm going to lecture a bunch, and then we've got a bunch of activities to practice all of these things. And then on Thursday when we come back, we're going to practice these things again. So we'll get a lot of reps on practice for this stuff. But basic principles of any strengthening exercise. 1, the overload principle. We want to, in order to increase strength, we have to apply greater loads than those are normally occurred. Specificity principle, the training effects are imposed to the exercising muscles, and the reversibility is detraining will reduce muscle performance. So indications for active range of motion: a patient is able to contract, control, coordinate muscular movements with or without assistance, and has no contraindication. That's an indication, is the lack of contraindications. That's pretty nice. All right. But really the benefits are desirable to fulfill the goals in the plan of care. That's a big indication. The contraindication, specific restrictions: don't contract this muscle. All right, well, don't contract that muscle. Unstable angina, heart attack within 30 days. Precautions: pain, joint swelling, acute osteoarthritis or rheumatoid arthritis, hemophilia, hypertension, or history of cardiac impairments. Really, what with these people, we want to avoid the Valsalva maneuver. What's the Valsalva maneuver? holding your breath as you exert force, right? So that also is with our MMTs. We want to make sure our patient's breathing. What's one of the easy ways to make sure our patient is breathing as they perform any exercise? Tell them to breathe, or what else? What was your answer? Tell them to breathe. Talking to them, having conversation, or having them count is another great way to. One, because I always stop count. I'm not counting your reps for you. And two, it's we tell them, no, it's to make sure you're breathing. You count out loud. I'll come back when you're at 28. To avoid other precautions, avoid unnecessary trauma. Great. And protect vulnerable structures, recent fractures, hypermobile joints, maybe integumentary. So benefits of active range of motion: maintaining physiological elasticity of muscle, maintaining strength, endurance, improve local circulation. So, oh, never mind. I'll get into it in a second. Increases awareness of joint motion and sensory awareness, maintains and improves cardiopulmonary function, prevents thrombus formation, structural integrity of bone tendon interface, and can improve strength depending on the strength of the muscle. So again, this is active range of motion as just active range of motion, not the big category of active range of motion. So improving strength at the appropriate MMT score. I think anything above a 3, we need now active range of motion will not improve strength. But at 3 out of 5, active range of motion can improve strength. And at some of the lower levels, if we've messed with gravity like we talked about. So first thing is we want to position our patient appropriately. So what is my patient position? What kind of support, what kind of stability do I want? What is the type of exercise? What is the area that I want? Do I need draping or not? Again, all of these things that we consider that is way more than just throwing an exercise at someone. Explaining goals, purpose, obtaining consent, selecting equipment, grasping as needed. Patient performs exercise smoothly and slowly throughout desired range of motion, full range of motion unless otherwise indicated. Some people, we can do this up to 90 degrees for now. And then the pause at start and end positions. Now in training, you guys do like pause reps, pause halfway through, pause at full range, right? So in training, there's some reasons for that. The reason why in rehab we pause at start and stop is because that little pause prevents substitutions of undesired motion, right? So that person doing bicep curls, if we were to have them pause at top and bottom of their rep, that's going to decrease their desire to kick in with the rest of their trunk. So there that is different than your pause reps in training. It's really just for technique and safety and to eliminate substitutions. Looking at performance, providing cues, corrections, patient performs predetermined number of reps. In general, how many reps, sets and reps? 3 sets of 10 is the most well-researched, the most bang for your buck. There are some patients who will deviate from that in the exercise class next semester, or we will look at that. But 3 sets of 10 is the biggest one, most common anyway. Evaluate patient response to treatment, including documenting findings, changing pain levels, cues, substitutions. I think this can be really important just because we want the next clinician to know what to look for, right? So if they needed cues to not extend with their trunk for their bicep curls, that next clinician we should give that person a heads up. So isotonic, same resistance, used to maintain or increase strength, power, endurance, promote circulation, cardiovascular efficiency, maybe create hypertrophy, maintain elasticity, maintain joint motion, enhance coordination. A lot of good reasons to do isotonic. So the isotonic is with, we have a concentric and an eccentric phase to it. When we are doing concentric, the 3 things we have to think of is, what is the muscle length doing? Is it lengthening or shortening? Is the speed increasing or decreasing? Or are we with or against gravity? I'm going to keep it with or against gravity for now. We're quickly going to add resistance. So if it's a concentric motion, what's happening to the muscle fibers? Are they shortening or lengthening? Shortening. Great. Speed. Are we accelerating or decelerating? Accelerating. If we only talk about gravity, is it with or against gravity? Against gravity. Good. So eccentric. Tell me more about eccentric. Muscle, the fiber length, the muscle length, lengthening, speed, decelerating, and then with or against gravity for now? With, same direction as gravity. Okay. So let's switch out gravity now. All right, so I've got my TheraBand anchored to the floor. I'm now doing bicep curls with this TheraBand. All right, so we don't have to think about gravity anymore. We have to think of the TheraBand as the resistance. So what's my concentric phase? Here to here or here to here? First one, right? All right, so this is a terrible example because I'm still against gravity as well. All right, let's do this. Bicep curls in this direction. Hold on, I gotta fix the camera. I'll curl. Yeah. You hold on, don't let go. All right. All right, so now I'm curling in this fashion here. For some reason. Actually, I've had a lot of sailors. There's a position in sailboats that you have to winch something. That this is the exercise I would do for it anyway. So if I'm doing a bicep curl here to here, now what way does gravity go? Down still. All right, but what way is my direction of force? This way, this way. Okay. Which is my concentric and eccentric phase? Where's my resistance? My resistance is here and it's pulling me what direction? That way. So it's with or against resistance now. Okay, so am I moving with or against resistance? Against, right? Because resistance is pulling me this way, my hand is going this way. All right, now I'm with, right? So this is my eccentric phase, this is my concentric phase. So thank you. As we get more reps with this, that can sometimes get a little bit more confusing, and especially in some more complicated exercises, we just have to understand where the resistance is coming from. Okay, that'll become more clear later. So prescription 3 sets of 10 is the most beneficial, the most bang for your buck, the most well-researched. 3 sets of 10 is way better than 2 sets of 10. 4 sets of 10 is not that much greater than 3 sets of 10. It really is the best bang for your buck. Now, here's the thing. The intensity, the load of the exercise has to be appropriate to make it worthwhile. If it's not enough load, then we are not going to get any strengthening benefits from it. So roughly 60 to 80% of 1 rep max is the most appropriate prescription. We could do 1 rep max testing in physical therapy. We could. I have my own thoughts on 1 rep. I don't think most people like doing 1 rep max testing. It's really a lot of exertion for our patients. It's a lot of time for us too. For me to guess weight and then try to add more weight. We did do this set. Like it's a lot of time. There are other ways we can estimate 1 rep max. Here's a bunch of weight, do as many reps as you can. I'll punch that into a calculator. The calculator estimates 1 rep max. I could do it that way. There's also 5 rep max and 10 rep max I could use similar fashion for. But I think for us, what we focus mostly on is our MMT score to appropriate strengthening prescription. And then where we want to get that 1 rep max test is somewhere in the 3+ to 4, upwards to the 4s. That's where we're going to want to be more diligent with our loads. I think the #1 problem in physical therapy is underdosing our exercise. I think, and in my text, you can look at me and tell me if I'm wrong or not. the patients who have 20 exercises, and not for different things, like not, oh, here's 5 for your hip and 3 for your elbow and 2 for range of motion, increase range of motion. No, the patients who are doing 15 to 20 strengthening exercises, all with the yellow TheraBand. To me, what are we doing here? We're not actually strengthening someone. So how do we know if we're not going to do a 1 rep max test and we're in the patient has some level of strength? How do we know if our exercise is intense enough? We could ask them. Well, so patients, we can ask the patient. Yes. I think one of the newer terms that I started seeing is reps in reserve. Does that sound familiar? Right. So we ask her, how many more reps could you do? Right. And then we could calibrate. Okay, well, that's way too many reps in reserve. We need this, make this harder. So we could do that. I'm always leery of subjective conversation from my patients telling me exactly what to do. I like to have an objective measure, or at least my thoughts. It's important and it's something, and for the patients who are really good at knowing how many reps they have in reserve, I think it's an acceptable one. For most of our patients, what if we were to say to our patient, and I'm sure you text that work, do it. Would you like to try the blue TheraBand? What's always the answer? No, I've got the yellow on here. I don't want to, right? So that's why I'm hesitant to ask my patients, because I know what their answer is mostly going to be. Very few patients would say like, no, let's bump it up. Like, yeah, most are going to say, no, I want to actually, let's go down a level. Like what's less than yellow? I don't know. So what other ways can we? So if they can't get through their full arc of motion, then it's too much load. We would need to decrease it. Or if they can't get to what number? If they can't get to 3 sets of 10. If their form is breaking down and if they're unable to exert the force to achieve 3 sets of 10. If they did 8 reps and you're happy with it, maybe you're okay with it. If they did 12 reps but couldn't do 13, maybe you're okay with it, right? There is a little bit of wiggle room. But yes, if they can't get to that number. All right, so that's if it's too hard. How do we know if it's too easy? They go too fast. They snap the band, maybe. Yep. Yeah. So maybe we could measure it with vitals, maybe. I also think it's not an objective measure, but you know the look of exertion on someone's face. You know when someone is just doing rows with the yellow TheraBand and chatting away and looking around, like, and they're not exerting, right? There's a certain look of exertion, even if they are doing 10 reps, like there's a certain focus and look on their face. So I think that's part of the lacking of science. What other ways would we know it's too light of an exercise? Load is not enough. I bet you that's I didn't think about that. Yeah. If you don't know what number you're on, this is way too easy, because I can count to 10. And I also know when it's getting hard, oh my God, it's this hard and I'm already on 6. Like I've got a lot more to go. Yes, I think that's another great way to put it. You lost count. It means we're 2. Yeah, I never thought of it that way. It's brilliant. Any other ways? So I think speed of motion, I think is an important one for us to think of. Losing count, I think, is brilliant. The look of exertion on their face, right? We need to be working hard. Now, that's the science to it. Art, there are some reasons to go easy at first. There's some reasons to stack up wins. There's some reason to start with the yellow TheraBand, knowing that we're going to progress quickly. But if we've been on the yellow TheraBand for 2 weeks, guess what? We are underloading that person. So again, I think this is my biggest pet peeve in all of physical therapy is we're just underdosing our exercise. So 3 sets of 10 with appropriate load. If the person does that 2 to 3 times a week, that is plenty to provide strengthening benefits. Now, you have a second for another quick pet peeve of mine? You're sitting here, so you have no place to go, so I'm going to say it anyway. If the frequency of strengthening only requires 2 to 3 days a week, why are we giving our patients home exercise program of everything that we already did in the clinic when they're coming 2 to 3 days a week? if the load is appropriate, we do not need the patient doing strengthening exercise when they're not with us. With some exceptions to that, right? Some of the art to that. Maybe I want them to practice the motion to get better at the technique. There's some art reasons for that. Science reasons, we do not need our patients spending any time doing strengthening if they're coming to our clinic 2 to 3 days a week. You guys that are techs, you guys giving home exercise programs and bands for the patient to do at home? Why?
Is they're not here.
So that's a great reason. If they can only come once a week, or we know they're going on vacation, we got holiday season coming up, we know that patients can't come in, maybe your schedule's packed and they just can't, there's no time for them to come in. There are reasons outside of the science reasons. Okay, good. How often does that happen? Okay. Maybe it's to not be afraid to exercise. If they go home with a sheet of exercises and a band that was appropriate for them, why do they need to come back to us? Ever. Just do this for 6 weeks and then you'll probably be better. If we did all of our job right. So that's a different thing. And I think that's absolutely true. But I also think we're wasting our time creating these home exercise programs that, one, the patient's not going to do because their compliance is very low. 2, they don't have time to do it. 3, they don't want to do it. 4, if we do it right, they don't have to do it.
And if you get it wrong at home, it might set you back.
And for our lifters in here, if you were to do bench press every single day, which is telling our home exercise program for our patients, do we tell them to do it every single day? When more days than not. Okay, so if we did bench press more days than not, what would happen to us? It gets jacked. Eventually, we would create some sort of tendonitis type problem. Eventually, right? So why are we setting our patients up to do home exercise program more days than not, and they're going to come in here, we're going to do it all at the same time? We are creating as many injuries as we're improving upon if we do it that way. So that is another one of my personal pet peeves. If we hit the exercise right, their home exercise program can be focused on things that they either can't do in the clinic, or they could be focused on range of motion. It could be focused on other things. I'm not saying home exercise programs are bad, but I think here's the sheet of the 5 exercises we did, and here's the band, and go ahead and do them every day of the week. More days than not, take Sundays off, right? So I think we're missing a lot of the science when we do that. So anyway, advanced exercise prescription is beyond the scope of what we'll talk about for this class. We could change depending on hypertrophy, strength, and endurance. Hypertrophy, we want lots of load for it. Strength, we want lots of volume for hypertrophy, lots of load for strength, low load, lots of volume for a really high volume for endurance. But beyond the scope of this class, we could also start talking about different energy systems. It's beyond the scope of this class. We'll touch on it for exercise in next semester and in cardiopulmonary in quarter 3. So isometric means same motion, no change in muscle length, often referred to as a set. These sets can be done with external resistance or without. Benefits: maintain muscle tone, increases strength when resistance is added, avoids pain associated with joint motion, improves stability of the trunk. So good with joint motion. Someone with knee osteoarthritis, sometimes doing isometrics throughout the arc of motion is the best way to strengthen the quads and hams and all the other muscles around the knee without going through that painful arc of motion. Sometimes that can be really beneficial. So that's what that pain associated with joint motion. That's the easy example for that. Does not improve cardiovascular fitness, joint or muscle flexibility, or coordination. So our prescription for that roughly every 10 to 20 degrees. So if I strengthen my elbow with isometrics at 90 degrees elbow flexion, there's about a 10-degree either direction. So I'm strengthening at 80 degrees and 100 degrees, that whole arc of motion. So if I'm going to do isometric contractions with my patient, it's roughly every 10 to 20 degrees, depending on the muscle that I want to work on. Holding for 6 to 10 seconds and resting for 6 seconds between contractions. No specific volume, like 3 sets of 10 is really easy. No specific ones. I try for around 30 reps. That's I try to keep it consistent for that. So that has to do with load. I want the external resistance to equal the amount of force the patient can produce. So I think it's best if we have manual therapist resistance for it. If we're doing muscle set, like glute sets and quad sets in a hospital bed, we don't need any type of resistance. We're just squeezing the muscle and relaxing. But in order to strengthen, I really think this is a therapist adding resistance thing. I don't think there's a better way to do it.
Isometrics done like against the wall.
Yeah.
Yeah.
Yep. Shoulder flexion, shoulder abduction, shoulder ER. Yeah, all against the wall or a post. Yeah, doorway, something like that. Yep. Can't get stronger than a wall. Unless you're the Kool-Aid man. Cool. Oh yeah, all right. Yep. So we could also talk about isokinetic. I've worked in one clinic with the isokinetic machine. That's the one, if you saw the machine with all the different levers and pads with the computer on it that we showed you a little while ago. So they're about $20,000 brand new. So a bunch of money. I can't get my outpatient clinics to get high-low tables instead of like stationary tables. But it's good for everybody's back. The patient get on and off. We can do all these other things. Not going to spend $1,500 on a high-low table. So to get 20 grand for a isokinetic, you got to work with a special population to need that kind of money. But they are really cool. And what's great about those, so we talked about it with testing. It gives us a bunch of data testing-wise. We can also use these for strengthening protocols too. We punch in how many degrees per second and the machine will not move. We exert maximal force and the machine will only move at that speed. It does strengthen more efficiently than isotonic, which can be really, really interesting. And some of the research on it is just amazing, the kind of gains you can get with isokinetic. But really expensive and bulky and really tough. All right, so next up, we'll talk about active assist. Patient contracts maximally while also receiving assistance from another source. Typically, it's easy to think of as manually, the therapist, but it could be with gravity or it could be mechanical. I think the pull-up assist machines in the gym are the easiest ones to think of mechanically as that assistance. But the reason I like manually, not only for isometric, but also active assist, is because we can modify how much assistance we provide based on the patient's needs. Versus a lot of those machines, one, we can't change gravity. Gravity is always just there. We can't change more or less of it. And a lot of those machines, like you say, okay, I want 20 pounds of assistance. When really I only need 20 pounds of assistance on this very short range. We as a therapist get to really modulate how much assistance that our patient has throughout that arc of motion. And the goal is to progress to active range of motion. So active resistive is next, most commonly known as progressive resistive exercise, PREs. Tex, you guys ever see anything documented as PREs? Yeah, you have? Yeah, but you have seen it? Okay, here's a question for you. Do you have a therapist in mind that documents that way? All right, what's the first word? No, progressive. PRE, what's the first word? I think you said good morning, first, John. In PRE, what's P stand for? Progressive. Okay. When the patient's doing the same exercise with the same load for greater than 2 weeks at a time, it is no longer PRE. We are just doing RE or same RE. Like no, progressive is the first effing word. Like just start progressing. So we should be changing. Our patients should never be just stagnant. Unless there's an art reason for it, but let's add some science to it. So active resistive requires some sort of resistance other than gravity, could be mechanical, manual. But gravity will have an impact on the exercise. So just like when I was doing my bicep curls out here, right, with the TheraBand resistance, gravity still exists. So it might not be affecting how I did my bicep exercise there, but gravity's still doing what? Pushing down, right? So it's trying to push my whole arm down. I gotta fire these deltoids in order to do it. So even though gravity didn't impact the exercise, the bicep curl that I was doing, it is affecting the exercise. So we have to consider that. Positioning of resistance can greatly impact the exercise because of the lever arm principle, right? So having our TheraBand anchored in my hand is a lot different than if I were to anchor it in my mid forearm. If I put my arm through the loop and did that. So also considering the length tension principle, muscles are strongest at its mid range and weakest at its fully elongated or fully contracted positions. And muscles can generate more force if pre-stretch, increase the vasoelastic force. So let's think of it this way. Who's feeling who can jump? Who can jump? Yeah. All right. Let's have you stand right here. Yeah, let's stand right here. Don't hit your bar on the black there, your black bar. Yeah. All right. So let's do this. Let's bend your knees about, I don't know, 15, 20 degrees. Yeah. And now jump up as high as you can go. All right, you try it again. 15 to 20 degrees. Stay there. Don't bend more. Okay. Now jump as high as you can. Good. All right. What did he do? First of all, which one did he jump higher with? Second one, right? And now what did he change to jump higher? He pre-stretched all right. He squatted lower and then he jumped up, right? So that stretch, the load before you explode. Thank you. Appreciate that. So sometimes I love using this because sometimes I don't need assistance when my patients are really struggling with that exercise. Sometimes I need to let them stretch the tissue that's about to contract and then ask it to contract. It's a really cool principle to start using. So anyway, that can be really important for some exercises. Open kinetic chain, proximal limb is stabilized while the distal end moves. Really good to isolate muscles. Good example of that is long arc quads. You guys talked about open versus closed kinetic chain and kines a lot, right? Yeah, you guys already talked about it this semester in kines. Yeah. Closed kinetic chain, the distal end is fixed while the proximal segments are moving. So really good to include weight bearing, involving simultaneous actions of synergistic muscles at multiple joints. The proprioceptive input that we get from being weight bearing is phenomenal and really important for some of our patients. We also add joint approximation, joint stabilization because of co-contraction, stimulation of proprioceptors. There's a ton of benefits to closed kinetic chain. Benefits of open kinetic chain is you get to work on the muscle, the thing you want to work on. You really get to pinpoint that. Closed kinetic chain, you got a whole host of other benefits. One limitation for it, though, is that we can substitute a lot faster in closed kinetic chain than we can open kinetic chain. So if you do have a weak muscle, putting that person in closed kinetic chain, they might be able to substitute. I think with squats, there's probably an easy way to see a bunch of substitutions. Just depending on how we position our hips. I'm either going to accentuate more quads or more glutes. If one of them's weak, I'm just going to do the other one. So being able to really look at that and look at the form and make sure that we're accentuating the muscles we want to be working is important. So I don't want to go over this right now because we've already been over it. Does anybody have any questions on exact exercise prescription based on the MMT? Everybody got a decent handle on it? Okay. So here's some passive range of motion we already practiced. So here's what I want for practice with active range of motion. Let's do 1, 2, 3, 4, 5, 6. All right, so this first part, we've got an exercise I want you to do in a position for it. I want you to identify the concentric and eccentric phases. So let's go. Why don't you join the girls here and you guys will do standing shoulder flexion. You 4 side lying shoulder flexion. Let's split you guys up. So 3 of you back there will do supine shoulder flexion, supine hip abduction. Let's go. You 3 will do short sit knee extension. You guys standing elbow. I forgot. I think I was meant to do standing elbow flexion. I think just standing elbow. Just stand and point your elbows around and then, yeah. Yeah. All right. So let's do that. It should be really quick, but stay with your groups because we'll stay there for the next activity too. So take a few minutes. All right. Standing shoulder flexion. What do you got? So I want to know what muscle and then the concentric and eccentric phases. Yep. Concentric phase. Yep. So anterior deltoid concentric phase here and then eccentric of anterior deltoid again. Yep. All right, good. What did you guys have? Side lying shoulder flexion. Ooh, tricky. Yeah, so we're side lying. We're doing shoulder flexion. What muscle is getting you from arm by your side to up over your head? What muscle? Anterior deltoid. Okay. How is it contracting? Concentrically or eccentrically? Concentrically. Okay, good. Ooh. What do you guys think? All right, so I'm not sure if that's concentric or eccentric or of what muscle, to tell you the truth. So let's go through our decision making. It first helps to know which direction gravity's going. Which direction does gravity go? Down still. God. All right. What direction is he moving in? Is he going with or against gravity? No, right? We're in a gravity min position, so we're not with or against gravity. Uh-oh. So then I don't know if it's constant. All right, let's figure other things out. Do we know which muscle we're talking about? If we don't know which muscle we're talking about, we can't tell if the fibers are lengthening or shortening, right? So that's trouble. All right. Get your hand above your head. All right, as he's pulling it back down to it by his side, is he accelerating or decelerating? He's accelerating back to his starting position. Yes, he is accelerating. All right. So, God, I'm glad we got one of these answers. Of our 3 questions, if it's concentric or eccentric, we said direction of force with or against gravity or resistance. There's no resistance. All right. So that we don't know the answer. We don't have any resistance. Is the muscle lengthening or shortening? Well, we don't even know what muscle we're talking about. So it's tough to tell if it's lengthening or shortening. The one answer we have is we are accelerating from when he's got his hand above his head to get it back down to his side. We are accelerating. Does that make sense to everybody now that we've talked about it? All right. If it's accelerating, what type of contraction is it? It's a concentric contraction. Okay. And what motion is he performing when he's going from he's going into shoulder extension. Does the anterior deltoid do shoulder extension? Not yet, right? Posterior deltoid, get all the way back up there. So now what muscles can pull his arm from fully flexed position to down into shoulder extension? Posterior deltoid, lats are probably a good answer. So it's going to be concentric of those muscles. See that? All right, good. What did you have? Supine? Oh, you were with them. Right. You guys had supine. Yep. Go ahead and go me. Show me.
Gravity going down as he brings there, it's uncentered. From 90 is the center of the anterior deltoid. But this kind of goes
All right. I love where you're thinking. I think this is perfect. All right. So you said something weird happens at 90 degrees is what you said. All right. So let's start from 0 to 90. What's happening and what muscle?
anterior deltoid.
Concentric. Everybody got that? All right. And then why is it after 90 degrees? Because now we were going against gravity, but now we're going with gravity. Okay. If we're going with gravity, it means it's eccentric motion because we're decelerating at that point, right? Okay. All right, so we're eccentric. So what muscle or muscles could be doing that? Slowing shoulder flexion. Exactly. Lats and posterior deltoid are the ones that are going to be kicking on to eccentrically slow and control that motion. Okay. Now coming reverse, what muscles provided that motion? Lats and posterior deltoid, because they're going to produce shoulder flexion concentrically. And then from here down, from 90 degrees down, anterior deltoid is contracting eccentrically. Does everybody get that? This was a really tricky one. You guys did a great job. Nice. Is anybody lost on that? A little bit? Okay. All right. Say that again. Go ahead and go back down. What?
So like when he brings it back down.
Yes. So from this position here, gravity's going this way. What direction is his force? Down. So he's going with gravity. So just that alone, we know it has to be eccentric. All right. What motion is he doing as we're doing this? He's going to shoulder extension. But if we're eccentric, it means whatever motion we're doing, it's the opposite muscle has to be slowing. Okay. So if we're going into shoulder extension, but we're slowing it down, it means a shoulder flexor has to be the one slowing it. Of the shoulder flexors, anterior deltoid is the best one. If you said, well, but the biceps break, yes, you would also be right. The coracoid, okay, fine. Like Lexi knows a lot. She's showing off now, right? But anterior deltoid is the best prime mover. Does that make sense now? And does it make sense now how this phase, when he's moving into shoulder flexion, it's eccentric, but it's controlled by the opposite muscle of the motion he's producing? Yes, you got that? All right, that is really tough to wrap our heads around. And anybody else? Everybody with that now? All right. What did you guys have? Supine hip abduction. Let's see. Good. All right. What muscles and how? Okay. Yeah.
Adductors that
Yeah. So there is no eccentric phase of this. It's concentric abductors, glute med, and then concentric adductors to go back. Does that make sense to everybody? Yeah, really good. Really good. All right. And then what did you guys have? Short sit knee extension. Easy one. Name more than just the rectus femoris. Perfect. Oh yeah. All right. So if you want, wow. All right. So if you wanted to change the angle, you could. You could. Little controversial on that, but that's okay. We'll go with it. All right. So you said kicking your leg out. That was concentric of the quads, and then when your leg comes back in, eccentric of the. Quads, yeah. All right, good. Any questions on that one?
Can you bias the eccentric? You said there's controversy on that?
Oh, no, not biasing the VMO is what she was talking about, and that is controversial. Yeah, yeah, a little controversy. It's one of those things. Art versus science. The science will say you can't really isolate the VMO. The best way to do it is actually walking backwards up a small incline on a treadmill. 12% is in my head, but that might not be 12%. So walking backwards on a treadmill can best research way to isolate the VMO. But here's the thing: if the surgeon says you need to work on your VMO, and the patient says, "Doc told me I had to work on my VMO." All right, fine, we'll work on a super VMO. Like fine, we'll do this exercise. Do you see how this goes? Oh, I feel that, right? So yeah, art, that's art. Science says I gotta find a treadmill and walk backwards on it. Art says just do this stupid thing for a VMO. All right, so there's a controversy about that. I gave you guys a different one. So you guys have standing elbow, and I said, okay, actually I want wall push-ups, and you tell me what's going on with the elbow. Sure.
Have your centric base, the triceps break out, and then your concentric short.
Perfect. Everybody see that? So we're going into elbow flexion. We did some weird things with how gravity is working, but gravity is still working here, and we're still going with and against gravity. It's just because we're on the wall versus with your feet out a little bit, it's not as much gravity as if you were on the flat ground. Okay. So the great thing about closed kinetic chain exercises is the co-contraction of all of the muscles. So yes, all those muscles are going to be kicking on, and that's one of the wonderful things about closed kinetic chains. So good. All right, any questions on that stuff? So same groups, stay in your same groups. We'll go around the room again. So create an exercise with a given patient position, must be activated, and resistance type. So we have TheraBands up here. We have weights back there, both dumbbells and sandbags. And then we also have the other option is manual, like therapist resistance. So this group over here, standing anterior deltoid. No, you know what? We're gonna go back around the room the other way. So you guys have standing anterior deltoid with manual resistance. You guys are standing anterior deltoid with weight as your resistance. You guys are prone anterior deltoid with TheraBand. You guys are seated hamstring with TheraBand. You guys are prone hamstring with manual resistance, and you guys are standing hamstring with weight resistance. Okay, so coming up, your patient position and your resistance, you come up with an exercise to get the right muscle. So what do you guys have? Sideline anterior delt, good. Okay, so if you wanted to make it an isometric contraction, what you did is pretty good. Make it an isotonic, or make it with throughout the full arc of motion. Yeah, yeah, keep going, keep going. Good. And then what about coming back? Got to get back. All right, good. So what's the mistake you made? What's that? So we could potentially increase our lever arm. Whenever if I'm really trying to focus on the anterior deltoid, I try not to cross the next joint down too. But I've got to protect myself, especially my patients exert a lot of force. I might use that extra lever arm if I have to. So good idea. What else? Body mechanics, I think would be improved, but it's not something I'm a little worried about right now. Yes, we switched sides with the force. So what he did, he said, okay, I need to add resistance. We're working on the anterior delt sideline. Go ahead and push into my hand. Push, 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 push. And he's exerting as much force like that it's really tough for his patient. There we go. And then he said, okay, to get back, I'm going to resist going back. All right, but what muscles did he just activate now? Now we're activating the lats and posterior deltoid. So in order to make this just anterior deltoid in the gravity min position, and in our MMT chart, this was one of them, right? Gravity min, but we need resistance. This is the 2 + 3 - range, right? I need to say, keep pushing into my hand here, keep pushing into my hand here, go back slow, keep pushing in, go back slow, keep pushing in, go back slow, go back slow. Pushing down. There's eccentric. Oh man, here we go. Everybody see that now? So push in hard, go back slow, keep pushing in, go back slow. Rest of them. All right, does everybody see that difference now? Because that is everybody, every single student that I've ever tried to do this to made the same exact mistake French made first. We switch our hands staying in the same spot the entire time. That makes sense? All right, who's next? What do you guys say? Standing anterior delt, piece of cake. Yep. Real rocket scientist over there, yeah. Very good. Piece of cake. All right, good. So what did you guys have? Seated after the TheraBand. Good. And give me concentric versus eccentric phases. Good. Good. Man, that's kind of funny, and it's because we're using the TheraBand as resistance, because what way does gravity go? Down. So if it weren't for the TheraBand, the concentric eccentric phases would be completely different, right? So that's where resistance matters. So really good. And I think if we wanted to be really specific, if your anchor point was high, yeah, try that. Now you see maybe even just like right there. You see how that line is pulled? It's just a little bit more perfect than when he's even higher. Right? Once we get there, the line of pull starts falling apart, or if we're really low, get really low. You see, we lose a lot for the initial like 45 degrees, right? So the anchor point when we're using a TheraBand or a cable column is really important.
Are we actually getting the muscle activation how we want it to throughout the arc of motion? And if we had to, there's some thought of, if Field's gonna sit here, he can change his exact anchor point to make a perfect line of pull throughout. I wouldn't do that because I don't want to sit here, I'll hook up this TheraBand to something else and then do it. But yeah, where our anchor point is matters significantly when we're using these TheraBands. Good. All right, what did you guys have? I won't answer your Delta with TheraBand. Give me 1 second. I gotta get close. What is this one? Great thought.
Here, so you have more. Here downside, you can go ahead and start your building. If he were to just bring it down by himself, he probably your concentric here. So I kind of so going with your myself. Still have that work eccentrically.
Okay, you don't need to do anything extra to make it work eccentrically, just the band itself is doing it, yeah, because that's the resistance we're talking about. So a couple things I'd like to see, anybody see ways we can improve upon this? Aiden, slide closer to the edge of the tape. So now, do you see where that shoulder is in position? It's not, we don't have to abduct the shoulder and then try to do shoulder flexion. So we're being more precise in our positioning. And then what's the other thing that I'm a little hesitant? I think you did a good job, but your body mechanics, yeah, we're always going to fix our body mechanics. I'm really not all that worried about it for this demonstration. I'm worried more about the exercise. Anything else that you guys are like, oh, what about that? Yeah, that's always a risk. I'd like it to not do that, but if there's a loop, that would make things safer. But yeah, it's not part of what I'm thinking either, because I'm not the one holding the band on the other side. I'm not concerned about it. The one I'm seeing is just a short arc of motion. Yeah, because the way you had your anchor point, like he's only getting resistance from roughly 90 degrees all the way up. So this is a tough position, and to use the TheraBand, I think we might have other options. This is just an exercise to show the importance of patient positioning and what is the tool we're using and exactly how are we doing it, right? So anybody can just say, do this exercise, but we are taking all of the knowledge that we've accumulated over the semesters that you've been here at CCRI, outside of this program too. Your anatomy and physiology from A&P 1 is being incorporated into this. So I think if your anchor point was maybe closer, yeah, so if we have it really high, go ahead and show me the motion now. Great. Starting to get a little wonky at the last 30 degrees. Yeah, try right there. Wow, that's pretty close to the whole arc of motion, right? Do you see that? You guys all see that? Where now if the anchor point's way too high, we lose a little bit at the end. If it's way too low, we lose a little motion at the beginning, right? So where is the anchor point is so important. And here's one of the tough things. I can't say, oh, for this exercise, put the anchor point here for this exercise. No, you have to, that's right before, your patient positioning with all those pillows. The last step is take a step back and just look. Does everything look all right? Same thing for this. Can I anchor point change a little bit, or are we okay here? Right, that's part of your job. All right, what do you guys have? Torn hamstring manual resistance. All right, let's see it. Yep. Good, not a bad isometric. Make it throughout the arc of motion now. Yep. I like that everybody's like, ooh, I like that. Tell them what to do.
He felt ice force. And I slowly breaks down.
There it is. There it is. You feel that in your hamstring? Yeah. So it is weird and it is a tricky skill to develop, to exert force eccentrically with manual resistance. That is a tricky thing. We're all going to practice it in just a minute. But remember, if we're only worried about the hamstring, if we're adding manual resistance, our force hand never changes. We put it on them and then we keep it there. Okay. All right. What did you guys have? Standing hamstring weight resistance. All right. Oh, there we go. Look at this. Yeah, there you go. And I would cue my patient to flex all the way that they can. And if they can't, that means what? Too heavy, too much load. So we decrease the load to make sure they can complete the arc of motion. Yeah, there we go. Nice. We could also put her on either a stool or a small step to make sure she's comfortable with that starting in full extension. That might help too. All right. So what I want to try next is every single person perform manual hamstring, exactly what Daniel had to do. Manual hamstring in the patient's prone, okay? All right, how'd that go? I like how you guys were focusing on your body mechanics for that. I really like that. How do you feel doing the eccentric phase? A little awkward at first, right? A little herky jerky. The patient needs to understand what to do too. That's a weird thing to do as the patient. So a little bit of learning curve, probably for that one when our patients do need it. But I think you guys did a great job. So next time we come in, what we're going to do is we're going to do these next two activities, open kinetic chain and closed kinetic chain exercises. And then we're also going to make, for each exercise, we're going to make these harder in 3 different ways, easier in 3 different ways, incorporate balance, incorporate cognition. We'll do some of that other stuff next time. But I think today, I hope some of the take-home messages are the dosing of the exercise, the intensity of the exercise is really important. Making sure we have enough load that we're actually creating strengthening effects to it. Again, there's an art reason to not, but that should be in a small time frame. That art is important, but for the most part, if we're going to be doing strengthening exercises, we want to be actually prescribing enough strengthening exercise. And then if you could really rethink about how you're doing your home exercise program, I think it would start making a lot more sense. And actually, go back on home exercise program for a minute. What's our compliance rate with home exercise program? Yeah, it's supposed to as zero as possible, right? So you have 1 or 2 patients that will do it, and then the rest aren't doing anything. All right, so how do you think our compliance would change is instead of giving our patients 5 to 10 exercises to do, if we eliminated all of the strengthening ones and just said, here, just do this one stretch. Just do this one to increase your range of motion. What do you think happens to our patient compliance if we approach it that way? We at least got a shot, right? So yeah, I think there's a lot of reasons for our home exercise program that leaves a lot to be desired in the physical therapy world. So I hope we understand the difference between passive range of motion and stretching and all the different mechanics that we have to for that. And I think we did a really nice job with the exercise selections that we did so far. Do we have any questions? Okay. All right. So we'll end class here.